Good afternoon, everyone. So it's a real pleasure for me to introduce Christine Lin to you for two reasons. One, I think she's a spectacular faculty member. And two, I think that this is a really fascinating subject. How you end up dealing with a transplanted lung and how the host and the environment interface in terms of that very interesting biological interface that occurs in all patients that are that have lung transplantation. Unlike other organ transplants where you have a situation where the organ is just exposed to the immune system of the individual, now you're being exposed not only to the immune system of the individual, but you're being stimulated by the environment. So Christine is an assistant professor of medicine in the pulmonary sciences and critical care division. She received her undergraduate degree from UC Berkeley in biochemistry and molecular biology, and then went to the University of California, San Diego to receive her MD degree. She did her house staff training at the University of Virginia, and then came here as a pulmonary fellow, and has not only excelled as a pulmonary fellow, but has worked in a very dedicated way in the lung transplantation program, understanding clinical lung transplantation and also trying to develop a research career focused on lung transplantation and understanding rejection of the lung, which is a tough field and a very exciting field. So she's going to provide some insights into that, and I really look forward to her comments. Please join me in welcoming her.
So I have to thank Dr. Schwartz for the lovely introduction. So as mentioned, my name is Chris Lin, and hopefully everyone will find this talk just as entertaining as I found to prepare it. So the learning objectives for today's talk are to understand the different phenotypes of chronic lung allograft dysfunction in pulmonary transplantation, as well as their associated clinical courses. I really want to elucidate and have everyone understand the components of both the innate as well as the adaptive immune response in facilitating CLAD, or chronic allograft dysfunction, and understand the implications and development of a personal interest of mine, which is donor-specific antibodies post-transplantation. Last but not least, we're going to spend a little bit of time identifying new therapies and modalities for the treatment of CLAD, and then hopefully we'll have a little bit of time at the end for questions and or comments. So I always like to start off my presentations with a little bit of history and background, because medicine is like that. You have to know where you came from. So let's go back, if I can do math here, 62 years. So back in Boston, Massachusetts at Brigham Hospital on December 23rd, 1954, a surgical team, which was actually led by a plastic surgeon, transplanted a kidney from one twin to his identical twin, who suffered actually from chronic glomerulonephritis. His twin actually survived for 9 years post-transplantation. This was in an era before immunosuppression, and this really kind of launched the era of solid organ transplantations, and being kidneys, they got the first get-go at it. So the next question then always comes up as a pulmonologist: what about the lungs? So the first lung transplant was actually performed at the University of Mississippi in 1963. This was actually performed by Dr. James Hardy, who was a surgeon doing a lot of research in dogs. Interestingly enough, the recipient that he picked was a recipient that we would never do today. He was actually a 58-year-old gentleman with lung cancer, and he was suffering from recurrent pneumonias as well as extrinsic airway compression, and was having a lot of complications from that. He went through a whole very complicated informed consent process and was actually in jail at the time, but did receive a donor who actually was doing quite well from a lung standpoint prior to his death. And the patient himself actually survived 18 days post-transplant. And the reason he actually passed away was not because of rejection, but actually because of renal failure as a result of the prolonged surgery. The next big breakthrough, however, in lung transplant came almost 20 years later, when at Stanford University in 1981, they actually performed 3 heart-lung transplants. And these were performed en bloc, so it's a pretty, in a sense, easy surgery, right? You just kind of glom out everything in the thoracic cavity and then just kind of push it back in. Two of those patients actually survived to their first post-transplant year. The third patient actually died 4 days post-op because of massive multi-organ dysfunction. However, the surgeon, when you read the paper that described these three heart-lung transplants, really said the reason they survived was because of, number one, excellent surgical technique, which is key. And then number two, cyclosporin had actually just been discovered about 5 years before and really marketed as a drug. And this was an agent known to have immunosuppressive therapies. Toronto actually performed the first, if you want to think about it, lung-only transplantation in 1983, so it's actually 2 years later. And it was actually also in a 58-year-old gentleman. This gentleman had idiopathic pulmonary fibrosis, and at that time, he was treated with a multi-drug regimen, including corticosteroids, and actually did quite well. When they actually published his findings, which was 3 years later in 1966, he was fully functional, off oxygen, and actually doing quite well. And so this was really considered to be something where a lot of physicians, especially pulmonologists in the United States, thought, we have a lot of patients with end-stage organ dysfunction. Now we can actually do something about it. So this is a graph that I want to draw everyone's attention to because it kind of drives home the point and actually the real reason why I'm giving this talk today, which is chronic lung allograft dysfunction. So survival in lung transplantation has actually gotten better, obviously, since we were able to do the first procedure back in 1981. And as you can see with each era, our 1-year survival is getting better and better, so that now currently it's over 90%. However, as you can generally see here, the slope of our survival curve has really not changed in the last 30 or so years. This really implies that chronic rejection still remains a huge problem because even now, at 5 years post-transplant, with everything that we do to all of our lung transplantation patients, and believe you me, it is a lot, they still only have a little bit over 50% survival at that time. And as you can see, at 10 years, it's quite dismal. It's around 25%. If you're looking at post-transplant cause of death in our particular patient population, not surprisingly, within the first 30 days of transplantation, the thing that kind of causes your mortality the most is going to be acute graft failure. So something that happens in the surgery, you acutely reject, maybe you have some antibodies there, maybe, not that this happens, but maybe you had a blood type mismatch, something causes acute failure of the graft itself. However, as time goes on, and it doesn't actually have to be that much time, 1 year to greater post-transplantation, the leading cause of death is actually chronic lung allograft dysfunction or chronic rejection. And unfortunately, lungs, they're the coolest organ, right? I have to say this because I'm a pulmonologist, but we are actually terrible at preventing chronic rejection, unlike pretty much all of the other solid organs, even intestine, which I thought was a little surprising. So the organ that actually has the highest 10-year survival rate are pancreas transplants, followed by liver, kidney, heart, intestine, and then lung. And believe you me, we've been in this dismal range, unfortunately, for a very long time. So the question that then comes up, at least the point of this talk, is what exactly is chronic lung allograft dysfunction? And when it was first elucidated, it was actually characterized histopathologically by obliterative bronchiolitis, which is essentially destruction of the terminal bronchioles. So unfortunately, to diagnose it, people had to get an open lung biopsy and or pass away, which is not ideal when you're trying to take care of a particular patient population. And then because we couldn't do an open lung biopsy on everyone to try to diagnose chronic rejection, what we did was actually come up with a clinical correlate of OB, which was called bronchiolitis obliterans syndrome, which is BOS. And this is actually based on a patient's pulmonary function test. So BOS was actually graded into 4 different stages and then a half stage, BOS 0P, basically depending on their decline of FEV1 from their peak post-transplant baseline. And you actually follow them over the course of years to determine whether or not they had these stages. And each of the stages, particularly BOS 2 and 3, were associated with a worse survival. However, back in 2011, since we're constantly changing our paradigms in medicine, they actually had a couple of case reports come out in the lung transplant literature, which actually emerged of a less common restrictive BOS phenotype that was different both clinically and radiographically from the classic BOS, which we were used to seeing. And so we now actually define CLAD as kind of a blanket term, chronic lung allograft dysfunction, as a sustained decrease in either your FEV1 or your FVC, less than 80% of your peak post-transplant value, and you can either have an predominantly obstructive phenotype or a predominantly restrictive phenotype. Make sense so far? All right. So I always like to show, I always have to show at least some flow volume loops during the course of this presentation, and essentially when we have lung transplant patients follow up with us in clinic, they get spirometry every single visit, and they get full PFTs at their anniversary visits, and we're actually easily able to see, do they have more of an obstructive physiology or do they have more of a restrictive physiology? And then, so looking at the subtypes of CLAD, the BOS phenotype, or this kind of obstructive physiology, you basically are looking at the things we always see with obstructive lung disease, things like decreased FEV1, decreased FEV1 FVC ratio. If you were to slide this patient through a high-resolution CT scanner, essentially what you would see are features of small airways disease. So you see air trapping, and these patients really have minimal to no infiltrates. So it's not like they have a lot of parenchymal lung disease in themselves. If you were to actually do an open lung biopsy on them, they would have obliterative bronchiolitis, so you would see this thickening of the airways, causing either obstruction or near obstruction of the lumen. And then the clinical course can actually tend to be fairly variable. A lot of the patients, when they're actually diagnosed with this BOS phenotype of CLAD, tend to have periods of plateaus followed by decline. So they'll actually do pretty well for a fairly long period of time, maybe have a little knockdown because they had an infection, and then kind of plateau again and then knock down. Some people do have a more rapid decline, but that tends to be a little bit more rare. And unfortunately, once you're diagnosed with BOS or this or CLAD, you're actually very poorly responsive to pharmacologic therapy. In a sense, the horse has left the barn. The restrictive allograft syndrome, the RAS phenotype, is this kind of more fibrotic type CLAD. And essentially, when you look at these patients' pulmonary function tests, they are restrictive. So essentially, their total lung capacity is less than 90% of what their peak baseline value was. And of course, this tends to get a little wonky when you have one lung that is transplanted and one lung that is not, but you just have to base it off their post-transplant PFTs. And when you actually look at their imaging, when it was first described, a lot of these patients had very upper lobe predominant fibrosis, which was kind of fascinating. And then they actually developed pretty extensive pleuroparenchymal fibrosis, and then you could also see features of obliterative bronchiolitis on these patients as well. This clinical course is actually much worse than the BOS phenotype. It's relentlessly progressive. Once these patients are diagnosed, they tend to decline very, very quickly unless they get another intervention, let's say a repeat lung transplant. However, it does tend to correlate, or it does tend to coincide sometimes with the BOS phenotype. So just keep in mind that these two kind of different phenotypes of CLAD can actually overlap. Like the BOS phenotype, however, this one is very poorly responsive to pharmacologic therapy. So why do I spend all this time talking about CLAD? Well, unfortunately, CLAD actually makes up a small but fairly notable proportion of patients who require lung transplantation. So if you were to look at the list, and I were to hand it to you today, we have quite a few patients on there that need one for idiopathic pulmonary fibrosis, COPD, a little smattering of cystic fibrosis, some alpha-1 antitrypsin deficiency, but there are also a good number of people that are on there because they developed chronic rejection, their allograft is failing, and to put it simply, they need a new one. And just before everyone falls asleep because they're not pulmonologists and not interested in lung, guess what? It happens in every other organ too. And I think what's really striking is that if you look at the pathology, if you were to put it under a microscope, chronic rejection in all the other organs kind of looks the same. In a sense, you actually it's defined by a marked kind of transplant arteriopathy, so you get thickening of the arteries as well as intimal proliferation, so the arteries themselves actually become occluded. And then, as one of my mentors like to say, you essentially get scarring of hollow tubes, right? So if you're in the kidney, the nephrons take a hit. If you're in the liver, the bile ducts take a hit. And so all of these things kind of occur in conjunction and are thought to be the result of just hit upon hit of immune activation. Risk factors for CLAD in particular, multiple episodes of acute cellular rejection, not unexpected, antibody-mediated and humoral rejection, which I'll spend a little extra time talking about, infection, viral, bacterial, and fungal. As Dr. Schwartz mentioned, the lungs, unlike any other organ, are pretty much open to the environment. Actually, the bowel is open too, but lungs more so. And notably, CMV can really cause an acute reaction in the lung itself. The degree of HLA mismatch at the time of transplantation, keep in mind that lungs actually aren't HLA mismatched when they are transplanted, just blood type matched. If you have primary graft dysfunction at the time of transplant, and then last but not least, the all-encompassing category of exposure. So acid reflux, GERD, it's huge, right? No one likes acid in their lungs. It's terrible, even for regular people. Smoke, secondhand smoke. A lot of former smokers do have people in the household that still partake in that particular habit. Any sort of environmental toxins, which can be inhaled or otherwise. And so all of these things can affect the allograft. All of these things can cause an immune response and then subsequently lead to the development of CLAD. So why does this occur? I've told you about what it is, what the risk factors are, and to answer this question, you really have to say, Oh, great. I'm going to go back and learn a little bit of immunology, which is what I had to do as a fellow, and that's just kind of what you do when you're trying to talk about rejection, right? So the thing is, talking about innate immunity and adaptive immunity are key to understanding kind of essentially why this process develops and also understanding the further directions that we can go in to try to arrest the process before it even starts. So innate immunity. Before I start, I always like to give a little bit of a background slide because I kind of need this too, as to cells of the immune system. It helps. So essentially, when your immune system develops, you start off with a pluripotent hematopoietic stem cell. You can either get a myeloid stem cell or a lymphoid stem cell, depending on signaling. And then these subsequently differentiate into two main categories of groups. So your myeloid progenitors tend to actually produce what we think of as the innate immune cells. So these are your neutrophils, eosinophils, basophils, mast cells. These are your granulocytes. They also produce monocytes, which can then subsequently differentiate into macrophages and dendritic cells, which are antigen-presenting cells. And then subsequently, your lymphoid progenitor is actually producing cells that tend to be more classically thought of those involved in the adaptive immune response. So T cells, B cells, NK T cells, as well as NK cells. I put a little asterisk next to NK cells because even though they are derived from a lymphoid progenitor, they're actually considered more to be cells of the innate immune system, but they have kind of fascinating and very plastic functions, which we'll go into a little bit later. And transplantation itself sets the scene for rejection, which truthfully is kind of a bust, right? We know the thing is whenever you transplant an organ, we already know that something is going to happen to it in the long term. So we're doing something to save someone's life, but transplantation itself, the actual process of taking out an organ, putting it in, causing inflammation is going to cause us problems in the future. And how does this happen? So first, when you go get the organ itself, things like your donor status. So how well is your donor? Is he sick? Is he not sick? Is he or she have an infection? The ischemic time of the organ, did you have to go to Idaho to go get the organ or was it local? All of these things affect the actual inflammatory milieu of the lung itself. The next thing that always happens post-transplantation, once we get it into the body, are infections and exposures. So infections actually lead to the upregulation of PAMPs, which are pattern-associated molecular proteins, which essentially come up in the sense of, for instance, if you're infected with E. coli, infected with Pseudomonas, maybe have a little CMV, your body recognizes these things and they're like, dang, I have to get my immune system going, so let's rev up because I'm detecting something that is causing me to kind of get everything rolling. Exposures do something similar, right? So they actually lead to the production of damage-associated molecular proteins, or DAMPs. And this exposure can be what I alluded to before in those risk factors. We're talking things like GERD, environmental exposure, cigarette smoke, etc. And then this all culminates into essentially activation of the innate immune response, right? This is the immune response that everyone's body has to fight off things like infection. You basically are having a injury, some type of inflammation. So therefore, once the innate cells get activated, you have complement activation, further cytokine production, and then this serves as a feedback loop in order to get everything going again. And it actually perpetuates this response. So when you're looking at innate immunity, specifically in terms of CLAD, we actually found that at least in lung transplant patients, IL-8 is a main mediator of neutrophil recruitment. It stands true in our particular organ as well. And we've actually demonstrated in lung transplantations in particular that it's upregulated in the presence of bile acids as well as particulate exposure. So people tend to develop a BAL neutrophilia, and there have been several retrospective studies that have demonstrated that patients with CLAD actually have an increased amount of neutrophils in their bronchoalveolar lavage fluid. Greater than 15% is actually associated with a response to azithromycin, which actually arguably may or may not be CLAD, but for the sake of argument, neutrophils do play a role in this response. However, the black box exists between neutrophils coming into the lung and then what happens afterwards. You'll find that I'll probably say that a lot from the time being. So moving on to our next cell in the realm of innate immunity, NK cells. These are actually pretty special cells because they can destroy targets in the absence of antigen priming, right? So you don't need the immune system to teach you, hey, this organ is not mine. NK cells will just go after it. And the main reason why is because of the missing self hypothesis. Essentially, if you have an organ or other thing in your body that doesn't have the same MHC molecules as you, your NK cells are going to be like, hey, not mine, and then try to attack it. And the effect on the allograft itself actually really depends on the balance between NK inhibitory receptors and NK stimulatory receptors. But interestingly enough, NK cells can also enhance T-cell mediated immunity. And within lung transplant patients, there are like neutrophils, there have been several small case series which have demonstrated that NK cells within BAL fluid actually have what's termed to be an active phenotype. So that specific subset of NK cells are actually those that are revved up and actually participate in inflammation. Last but not least, I could not let innate immunity go without talking about macrophages, which I think are a pulmonologist's cell of choice, even though I don't study them, sadly. So macrophages are kind of cool, right? So you have peripheral monocytes, which then can come into the tissue, or you can have resident macrophages. And they really can augment the acute inflammatory response, which, as I mentioned, is a risk factor for chronic lung allograft dysfunction. And then animal models in all solid organ transplants, so kidney, liver, lung, heart, have demonstrated accumulation of these cells within the allograft, actually at all points post-transplantation. The thing is, no one really knows what they're doing. And the problem is because macrophages have a lot of different phenotypes. So classically, they're divided in either M1 or M2, which is inflammatory versus fibrotic. It's an oversimplification, to be sure. But a lot of times, within specific animal models and within human studies, it's actually really difficult to determine what exactly is that macrophage doing at any given point in time. Is it repairing or is it disordered? And so a lot of times macrophages have been kind of studiously ignored in transplant just because it doesn't really prompt acute rejection, but we know it plays a role in the inflammatory milieu. So this brings the focus of my particular talk on the immunobiology of transplantation in terms of adaptive immunity. And innate immunity, which I think is fascinating and I think deserves a little more recognition. However, the question then becomes, why is adaptive immunity such a big deal? And the reason why is because 54 years ago, they did this one, actually not just one mouse experiment, but they did this one mouse experiment, which essentially was as follows. So in this particular experiment, they transplanted a skin graft, we'll say from this brown mouse onto a white mouse. And they found that over time, white mouse rejected brown mouse skin. Makes sense, right? This is a fully allogeneic mismatch, doesn't like it, recognizes it as foreign. They actually found that when you transfer the lymphoid cells from that sensitized animal onto another animal that has had a skin graft, you can actually cause faster rejection of that skin transplant. So they're like, this is a little interesting, right? Something in those lymphoid cells, whatever they may be, is actually causing rejection. And they found that when you transferred serum, which contained antibodies, no, didn't really do anything, right? These mice rejected at the same tempo as the prior mice did before. And so they really concentrated their efforts, and by they, I mean essentially a lot of PhDs and MD PhDs at the time of transplantation biology on these lymphoid cells, and they found that T cells were the main driver of acute rejection. So a little more background again. T cells are essentially divided into two types, which are CD4 T cells and CD8 T cells. CD4 T cells are classically referred to as helper T cells. So they release cytokines. They interact with B cells in order to not only facilitate antibody production, but then also can cause class switching of antibodies itself. They can augment cytolytic activity actually of CD8 T cells. And then, even though I'm not going to spend a lot of time talking about this, a special subset of CD4 T cells include Th17 cells, which are important in autoimmunity. CD8 cells they're soldiers. They're soldiers of the immune system. They're cytotoxic T cells. They promote target cell apoptosis. They're really good at doing what they do. And they actually have been demonstrated in both human as well as mice to be able to acutely reject allografts on their own without any other cell involved. So because of the fact that the evidence for T cell involvement and rejection was so convincing, that's where we focused a lot of our effort. And there is no doubt that T cells are central to allograft rejection, both acute and chronic. Because they can mediate direct lysis of allograft cells, because they can activate accessory cells, because they facilitate antibody production, and because they facilitate complement activation, they basically act in all aspects of the immune response, and they do it very well because they're specific for a particular antigen. Now, interestingly, T cells require activation of both T cell receptor as well as co-stimulatory receptors, and because of this, they are the main target of immunosuppressive therapies that we use within transplant today. T cell rejection in lung transplantation is very well defined. They've had many consensus statements about this, and it's actually graded 4 grades, actually 5 if you want to count no rejection, which is a 0, but based essentially on the infiltrate itself as well as the location of the infiltrate. And as you can see, progressing from A1 to A4, you essentially have more cells involving both the lung parenchyma as well as in the perivascular space around the blood vessels itself. And the very strong association between acute cellular rejection and between CLAD really highlights the key role of the adaptive immune response in this process. What about B cells, though? So these are actually my personal favorite because people tend to ignore them, right? So in that initial experiment that I told you about with mice, I told you they transferred the serum and nothing happened, right? They didn't reject the skin graft. So we all know skin transplantation is not organ transplantation. So I think a couple of scientists were like, let's see if B cells can really do something, or let's see if antibody can do something on its own. So acute humoral rejection was first described in renal transplantation in 1966. And this was very early, right? You put a kidney in, there's a mismatch, bam, kidney turns black, doesn't work anymore, need a new transplant and or dialysis. In 1968, which was only a few years later, they actually found the development of donor-specific antibody, or DSA, was associated with worse renal function. In 1991, they actually were able to elucidate a number of studies in which they detected a complement product, C4D, in greater than 50% of patients with late or chronic rejection, also in kidney transplants, really suggesting a role for antibodies. Lungs were first kind of entering the literature in terms of DSA back in 2002, which is relatively recent if you think about it, where they found that de novo DSA development was associated with BOS, didn't understand the causality between them, and then last but not least, they actually got a bunch of people together back in 2004 to discuss AMR specifically in thoracic transplantation, both heart and lung, because before it was really considered to be a non-entity. Now, however, it's been increasingly recognized that B cells and antibody actually play a very big role in the development of chronic allograft dysfunction, which I think wasn't appreciated earlier. Looking at B cells themselves, they can actually have reactions that are T cell independent as well as T cell dependent. As I mentioned, importantly, they're responsible for the production of donor-specific antibodies, but B cells alone can also enable lymphoid organogenesis and promote the development of dendritic cells, which are professional antigen-presenting cells. Once those cells get prepped, they are all about presenting foreign antigen, aka your allograft, to the rest of the immune system, thereby perpetuating the response. And then last but not least, even though we always think of T cells kind of helping B cells can actually help T cells in reverse, and they can actually regulate several aspects of T cell function, specifically CD4 or T helper cells. Antibodies, just to speak to that for a little bit, can actually do a number of things as well, including complement-associated cellular damage. They can actually activate platelets and inflammation through increasing von Willebrand factor. They can upregulate fibroblastic growth factor. They interact with leukocytes and then actually cause antibody-dependent cellular toxicity. And then specifically in lung transplants, what we've actually found is that antibodies to cryptic antigens, which are unmasked during the time of transplantation, for instance, to K-alpha-1 tubulin as well as collagen 5, can actually cause a autoimmune response, if you want to think about it that way, post-transplantation, and can actually lead to some features of kind of autoimmune disease in the lung just because you now have these antigens which were prior not exposed, now being exposed, and then the development of these antibodies. Just to go through a couple of the clinical studies in lungs themselves, the first time antibodies were actually first demonstrated was a retrospective review conducted at Duke University back in 2000, basically demonstrated that anyone who was pre-sensitized or who had antibodies had an increased number of event days, an increased incidence of BOS, and a decreased trend towards survival. And then subsequently, they had 2 follow-up studies at the University of Pittsburgh, which kind of hammered home the point that HLA antibodies are not only associated with high-grade acute rejection, but also multiple episodes of acute rejection, and was actually significantly associated with the development of stage 2 to 3 BOS, which is end-stage disease. So clearly, antibodies are now doing something, and I think it was being, within the last 10 years or so, being increasingly recognized in thoracic transplantation. So that kind of brings me a little bit to a kind of a segue in my talk where I would say that because antibodies now have a new role, what we really want to kind of understand or really appreciate out of the entire process is that even though I've described all of these cells in isolation, and even though I've talked about them individually and what they do, the thing we have to keep in mind about the immune system is that it's extraordinarily complex and that none of these things happen in isolation. So just taking a step to the side, what I wanted to talk about briefly was a little bit of my research, which is actually looking at basically the connections between both the innate and the adaptive immune response, specifically antibody, and how they contribute to chronic rejection. So I'm not going to bore you with the mice strains that I used because you might glaze over if immunology hasn't made you do that already. But long story short, I essentially work in a cardiac transplant model. I know, being a pulmonologist, that seems a little rough, but I haven't mastered mouse lung surgery yet, but mouse heart surgery, totally can do it. And essentially what I did was we developed a chronic rejection model, which actually demonstrated that NK cells, in conjunction with antibody, can actually promote chronic rejection, which is fascinating in itself because we're saying that a product of the adaptive immune response aka antibodies, as well as cells of the innate immune system, aka NK cells, which are really not affected by our current immunosuppression, can actually cause thickening of the vessels, which is measured by this thing here called the neointimal index. And just because a picture is worth 1,000 words, when you actually look at the hearts of these mice that develop chronic rejection, when you actually look at them grossly, all of these hearts are beating, and they're doing quite well. However, they develop these significant coronary artery lesions that are characterized by intimal thickening and near occlusion. And what's really striking is that these vessels can be right next to each other. So these are very heterogeneous lesions, and they're actually very similar to the lesions that people develop in terms of chronic rejection post-heart transplant within humans. So I think it's really fascinating that you're saying, what is the result of my particular brand of research? We're really showing that, one, the immune system is complex, that two, that there are definite links between the innate and an adaptive immune response, which I think is key, because we're really saying that, guess what? That T cell that helped produce the antibody in the first place, you don't actually need it to actually facilitate a long-term chronic response. And then last but not least, there's a real redundancy in the immune system. Essentially, what I'm saying here is that NK cells can damage graft in a similar mechanism to, say, CD8 cells, which we later showed. And that really, in a way, poses some problems with therapies, right? Because you think to yourself, great, I totally beat up the adaptive immune response, those T cells, getting crushed by all my pharmacologic therapy, but everything else, which is still relatively untouched, still has the ability to essentially do the same thing, which I think is a key thing to keep in mind. So the immune response, it's a 1-2 punch, as I like to describe it. You have antigen exposure, innate immune activation, followed by adaptive immune activation, recurrent injury, and then things just cycle back to each other to the point where, guess what? As I said before, transplantation sets the scene for rejection, and you're constantly fighting a revving up of the immune response and a constant cycling of the immune response, so this is something you have to be cognizant of. So nothing summed this up better than a really complex PowerPoint slide, which I'm going to walk you through. Hopefully it's clear. So to sum everything up, risk factors, ischemia root perfusion injury, a little primary graft dysfunction, a little bit of acid reflux. Infections, I have a pneumonia, CMV reactivation, I have some pollutants, I have a long-term smoker. Allergenicity, I had an MHC mismatch at the time of transplantation, or self-antigen exposure. My GERD caused some collagen 5 to be exposed. This all leads to essentially activation of the immune system, both innate as well as adaptive immunity, which feed back on each other. Autoimmunity, as I mentioned, also plays a role in terms of anti-collagen 5 and anti-K-alpha-1 tubulin antibodies. This can lead to the promotion of growth factors, different proteases. My favorite, I'm just going to say MMPs. Can I say that right now? Inflammation, complement, perforin granzyme, all of these things come together to essentially constantly cycle between wound healing and fibrosis. And we as pulmonologists, and a lot of pulmonologists much smarter than I am, really study this in native lungs, right? Wound healing versus fibrosis. And this, I think, is a very common message in post-transplant, which actually raises a question of are the similar mechanisms causing disease in native lungs, can the same things be responsible in transplant lungs? Eventually, this leads to CLAD, as characterized by small airway obstruction, alveolar obliteration, and decrease in your terminal bronchioles due to essentially collapsing of the lumen because of smooth muscle proliferation and then cellular proliferation of the actual airway cells themselves. All right? So last but not least, we always want to talk about treatment because as clinicians, this is something that I think that we really want to care about, right? I think it's great to spend time in lab because you learn a lot of really cool things. But the thing is like when it comes down to it, we want to see patients and we want to say that we want to do something for our patients, which is why we study what we study. And so treatment strategies for CLAD, essentially, at the current time, are really based in, guess what? T-cell specific therapies. So I'm just going to kind of go through all these as a shout out to the pharmacologists in the crowd. Let me know if I get anything wrong. So first off, steroids. A personal fave, not my personal fave, but a personal fave among transplant physicians, right? So these are classic immune, kind of a generalized immunosuppressive agent, if you want to think about it this way. In theory, what they do, transcriptional regulators of leukocytes, they affect leukocyte distribution, as well as leukocyte function. And interestingly enough, actually at the beginning of the whole lung transplant phase, they actually were not used because they thought it would impair wound healing, but we use them now. Next thing, calcineurin inhibitor. So this was a cyclosporin that I alluded to, which was discovered back in 1976. We now have another one, tacrolimus. I'm not sure why there's an E in front of it. Apologies. But essentially, these two medications inhibit the phosphatase activity of, guess what, calcineurin. which prevents nuclear translocation of NFAT as well as, and then the production of cytokines, which then cut down on T cell proliferation. The next class of inhibitors, inosine monophosphate dehydrogenase inhibitors. These include mycophenolate mofetil as well as azathioprine. These essentially block GMP synthesis, which once again is required by proliferating T and B cells, so very lymphocyte driven. And then last but not least, the mTOR inhibitors, or this is the rapamycin and everolimus. Essentially, they inhibit mTOR, which is a cell kinase, which results in blockage or progression from G1 to S. So essentially, your cells cannot divide. And so all of these, consideration-wise, as you can see, the majority of these therapies are based on non-specific modulation of T cell signaling pathways. And because we've been studying T cells for so long, because it's been 50 years since people first showed that T cells were important, we actually, in general, pretty much understand and can pretty much control this response, right? If somebody comes into clinic and they're saying, you know what, Dr. Lin, I'm not feeling well. They have a decrease in their FEV1. They have a little bit of an infiltrate, and they have biopsy-proven acute rejection. I'm like, I know exactly how to treat that. And I drop a couple of medications, person's function recovers, and then I give myself a little pat in the back. However, the thing is that because it's non-specific immunosuppression, it really is associated with a lot of side effects, including increased risk of infection, development of malignancy, and then each of the drug classes, which I mentioned, are actually associated with specific side effects in themselves. For instance, corticosteroids are associated with development of metabolic syndrome, osteoporosis, cataract development, et cetera, et cetera. So in terms of treating B cells, annoyingly enough, there's actually no agreed upon definition for AMR in the literature. They actually did have a recent consensus statement, but even within the consensus statement, they're like, we don't really know what this is, but that's cool because I have shown that they're important. And so for treatment of antibody-specific diseases, we have IVIG as well as plasma exchange, which essentially do what they do in every other antibody-mediated disease that we may treat, which includes pleiotropic mechanisms, including blocking cytokines, complement. They do modulate antigen-presenting cells as well as T cells. We can actually give rituximab, CD20, which is a chimeric monoclonal antibody, and CD20 is primarily present on B cells. And then we also have two other drugs which have been used here, but very rarely, eculizumab, which is a terminal complement inhibitor, as well as bortezomib, which is a proteasome inhibitor. The proteasome inhibitor is used because it's thought to affect antibody secretion by plasma cells. So the thing that I want to point out about all of these therapies is that they are good in theory, right? They all affect the B cells in some way, and we have demonstrated that. However, the thing is that clinical AMR is really ill-defined, and it's very rare that we actually have somebody meet this definite definition of clinical AMR, which means my lung is not doing good, I've excluded other causes, I actually have histology consistent with AMR, there is complement deposition, and DSA is also present in the blood. Most of our patients kind of fall in this probable or even possible category, and so the question always arises, which of these drugs do we use? Should we use them? When should we use them? And a lot of this is actually fairly ill-defined. Considerations for treatment of B cells is that DSA really actually develops in the majority of patients post-transplantation, up to 55%, but in many cases, the significance of DSA can be unclear. A lot of times people can have antibody present, but not exactly have evidence of allograft dysfunction. And then within lungs themselves, there's really limited data describing the management of AMR, no randomized trials, no head-to-head comparisons. And then, of course, there are always differences between different transplant centers as to where, how, when to treat. Other modalities for treatment of CLAD that are aside from specific T cell and B cell therapy include initiation of macrolide therapy, as I mentioned, little BAL neutrophilia, you may respond. Addition of methotrexate for the addition of presumed anti-fibrotic properties. And then last but not least, something that we've undertaken very rarely, which is photopheresis, which essentially was first discovered for the treatment of cutaneous T cell lymphoma. But now we're like, hey, maybe this will work. Essentially what happens is that you remove the patient's blood, you remove the leukocytes, you irradiate the leukocytes, and then for some reason you put them back in. That's cool. But you put them back in, they die because they've been irradiated, and then that death is actually cellular apoptosis, which for some reason modulates the immune response and then actually makes these people better. That's a lot of hand-waving because that's the best I could find in the literature as an explanation as to why photopheresis works. Now, but then again, I think it really speaks to the fact that we're really, again, looking at some sort of immune-mediated process. But really, the question then becomes, with all these therapies, which everything we've talked about, I'm just going to head back to this one of the initial slides that I showed, which is, guess what? even with everything we do, we're still not very good at preventing chronic rejection. And it kind of makes you wonder, and it makes me wonder as a clinician in lung transplant, you know, did the horse leave the barn way before I even thought about it? You know, is the cat out of the bag? I can't think of another metaphor right now. And basically you're saying, are all these immune things happening, and I just wasn't smart enough or cognizant enough to catch it when they were happening. So once it's done, right? CLAD has happened, it's irreversible, the immune injury is done. Well, that's kind of a bust, right? Might as well just give up on my career now, et cetera, et cetera. But guess what? It's not, right? So we always want to make things better for our patients. I want to be able to say in 10 years when hopefully I'm giving grand rounds again, and I'm just kidding, that the 27% bar that's on the chart is a little bit higher. And the thing is, you look at it and you say, which direction are we going now? Seems extraordinarily complex. And I think one of the key directions that we have to go are, one, looking at regulatory immune cells. And this is something that I'm looking at in my animal models right now. So the immune system, in case it wasn't obvious, is a little bit more complex than what I presented in like the last 20 minutes or so. And for every cell that I mentioned, there's some type of regulatory cell that actually makes things better. When I say makes things better, it's been shown in animal models, mainly of kidney and heart transplant, that you can actually generate tolerance to your allograft, which is the holy grail in transplantation. So you have things like tolerogenic dendritic cells, regulatory macrophages, mesenchymal stromal cells, NK cells. Those NK cells, which I said cause rejection before, guess what? You flip over the receptors, you change a few transcription factors, bam, now they can actually do things like kill cytotoxic T cells and actually flip the immune balance. You also have regulatory T cells, which are huge, CD8 T suppressor cells, as well as regulatory B cells. And something that I'm studying right now is actually the work of regulatory T cells and whether or not they can actually modulate the innate immune system in my particular model of chronic rejection. So we'll see. Stay tuned. I think a lot of the talk also really depends on other things, kind of thinking outside the box. We can always talk about small molecule inhibition, but really cellular therapies, I think, are a way to go. Investigation further into regeneration and repair processes, and then actually even thinking outside the box more, and this is something that's actually been explored at some of the larger transplant centers, looking at things like gene expression profiling, and then actually diagnosing or finding a biomarker and or a expression profile for CLAD that precedes your clinical decline. And I think that's going to be the key thing really in the long run, is to be able to identify it before it starts, before the horse leaves the barn or the cat leaves the bag, and be able to say, guess what, I think this patient is going to develop chronic lung allograft dysfunction. These are the signs and symptoms. This is what I'm worried about. We're going to treat them now. We're going to treat them with these specific therapies because these cells are involved. And really, I think it's unfortunately too expensive to take on really kind of in a large cohort, but something really fascinating to think about where patients, specifically transplant patients, can get specialized immunotherapy that can really help guide and to allow for allograft longevity. So before I go, I always have to thank the people that made my talk possible. So I know I didn't spend a lot of time talking about my mice or my research, but I do have to thank everyone in my lab, specifically my mentor, Ron Gill, as well as everyone in the lab who helped me with my projects, my clinical mentors, as well as those on my research committee, and then the funding that I received from both the CCTSI as well as the ISHLT. Thank you, and I'll take any questions.
I was really intrigued by the neutrophil radiation model that you showed. And it made me start thinking that perhaps the radiated neutrophils were acting as a decoy to the immune system. And is that being pursued as a potential way of treating focused immune response in the lung to create a decoy that would attract the adaptive immune system?
Yeah, that's actually an interesting thought, not specifically in lung. I do know that there are a couple labs on campus that are looking at basically the inflammatory microenvironment between cellular apoptosis and cellular necrosis, which obviously release a lot of different things and can activate the immune system in different ways. And so you wonder if actually, causing cellular apoptosis versus necrosis does kind of switch the immune response, and because of that, does act as that decoy. But I don't think that's being specifically studied in lungs. As I mentioned, they're very limited models. We don't actually do it here too frequently. Marty may know the last time we did photophoresis on someone. about a year ago. It's not something that we've seen done too commonly, but it'd be interesting. I don't know if we actually take blood samples from them or not. So.
Other questions?
Can you speak a little bit to the difference between the BOS phenotype and the RAS phenotype, and if there are differences in the immune milieu in each of those?
I think that's a really good question. And so basically when you're looking at like obstructive versus restrictive, what they basically been coming to in the literature is that the kind of subdivisions of CLAD are actually relatively new, right? They came up within the last 5 years. And when you read through a lot of the consensus statements and a lot of the papers that have looked at essentially these single center studies that look at CLAD post-transplantation, a lot of the risk factors actually are the same. The question, I think, then becomes what changes the remodeling, like what aspect of immunity changes the specific remodeling of the airway versus, say, parenchymal disease versus pleural disease versus not. And I think that's actually one of the key things. And I think it's telling that the RAS phenotype is so much more clinically progressive than the BOS phenotype. It really does speak to a disorder in that I think repair, injury and repair, even though the risk factors themselves are the same.
So let me raise a controversial topic. From my point of view is that this is an airway-centric process.
Mm-hmm.
So that would then make me wonder what in the airway is causing this immune response in the respiratory bronchioles and in the very small airways.
Mm-hmm.
And yet it seems to me that not enough work has gone on in terms of understanding the acute innate immune response that might be stimulating this adaptive immune response.
No, I agree. And I think that there are a lot of, and I think that the key thing to remember about the innate immune response is that it comes up not only at the time of transplantation, but that it's constantly coming up. And I think that there are a lot of factors. We talked about infection exposure, but also airway hypoxia, which actually brings about a fairly significant innate immune response. So as your graft is failing, your increasing hypoxia changes that environment as well. And so that's why I think that really when you look at investigators, even though, yes, T cells can do amazing things and they actually drive a lot of transplant rejection, the point that I'm trying to make and why I do study a lot of innate immune cells is that they really have a lot of functions very similar to it, and what's really been shown is that they can also have memory and antigen recognition just like T cells. And so I think that further investigation into that is absolutely necessary. So
you may want to explain why there could be airway hypoxia.
Oh.
In terms of bronchial circulation.
Sure. So at the time of transplantation, because it's a little bit of interesting fact. So the thoracic surgeons always describe to me transplant as sewing up 3 holes. Right, so which sounds to me an oversimplification of lung transplant. But the key thing is here is that unlike pretty much any other organ, we actually do not reanastomose the bronchial artery circulation. So the lungs have 2 forms of circulation: the pulmonary arterial circulation and the bronchial circulation. Bronchial circulation is about 15% of the blood supply, but it's actually highly oxygenated blood. We do not hook that up at the time of transplant, so that just kind of goes by the wayside, and essentially your oxygenation is delivered just by your pulmonary arterial circulation. So already you're kind of at a transplant patient's at a little bit of a disadvantage because they essentially do not have that arterial blood going to supply the lung itself. So their tissues are at a level of hypoxia that's more so than, say, you or me. What's interesting is that they actually do bronchial artery reanastomosis in centers in Europe, and they actually do it at Cleveland Clinic here in the U.S., and they have shown a decreased incidence of BOS and increased time to BOS. So they actually go longer before they develop CLAD or chronic rejection. So, all right.
Chris, very, very nice talk. So you mentioned at the end, one strategy of this would be identifying who's going to reject earlier on, and right now it looks like you're using sort of more blunt instruments, looking for X-ray changes, how do they feel, et cetera. But if this is an immune-mediated response, then you alluded to that the future is looking at maybe Affymetrix or high-throughput arrays or RNA-seq arrays. But if we know this is immune system mediated, has anyone sort of delved into other biomarkers yet, such as cytokine release that might imply?
They have. So there's actually, Yeah, no, I'm sorry to interrupt, Dr. Bull. So there's actually a laundry list. Sorry, there's actually a laundry list of about 30 different biomarkers that people have looked at, kind of like the main ones you would think people would look at in terms of both fibrosis as well as inflammation, a variety of cytokines, as well as other protein markers, and they've all kind of failed, actually, at really being a good predictor of CLAD and really being correlative with different stages of CLAD itself. So that is ongoing.
Is there any correlation between the rejection phenotype that you see in one lung transplanted into one patient and the same lung from the same donor transplanted to another?
Ooh, good question. So you mean their lung brother and or lung sister, as I like to call them? So actually, truthfully, I'm not sure. The coordinators may be able to speak more to this. I don't know who has a lung sibling, and so I wouldn't be able to say one or the other. I would suspect absolutely, because essentially the recipient's immune system is they're very different in between. Say if you put a left lung into one person and a right lung into another person, I would suspect that their time course to rejection would actually be different. But I can't say I know any data to back that up, or if that's actually been looked at in the literature.
Are you asking if it's OB versus RAS?
No, I think he's asking like if you took lungs from one donor and they went into separate recipients, do those separate recipients have the same tempo to chronic rejection because they came from the same donor? And I would say no, just because the recipients were different in terms of their immune milieu.
Yeah, and the reason I asked that question is one of your early slides said that one of the determining factors of the rejection process are intrinsic issues related to the donor lung.
Yes. So
Case there could be.
it is true that is one of the risk factors. Remember, that is one of about 50 risk factors. I shouldn't say 50, but it's one of many risk factors. And I think that even though that risk factor may be common between, say, the two recipients, you're also looking at a host of other risk factors which are going to affect the immune response. For instance, let's say one recipient has really bad GERD and needs a Nissen, other one doesn't. One recipient is colonized with Pseudomonas and the other one is not. And so I think these things are going to affect it as well. Dr. Braun?
Going at it from different directions. Whenever I transplant in different directions, I realize that the vectors are going different. But this degree of type 1 HLA mismatch, and when you choose the transplant, then you type them next to the donor and the patient. The degree of mismatch determines predict the degree of chronic rejection.
No, that's a good question. So,
And then, if so, that study's been done a long time ago. What degree of anti-lymphocyte therapy, to use a slang term, make a difference? Does one modulate one's degree of immune intervention based upon degree of type 1 mismatch?
yeah, I think that's a good question. So they've actually looked at this retrospectively in lungs to determine if degree of HLA mismatch is associated with CLAD, and it is actually not. If it were, we would actually match them, but because it's not, we do not at the time of transplantation, although, it kind of depends on who the recipient is, if they're presensitized and all that other kind of thing. There's actually been a lot of literature, actually not in lung transplantation, but in renal transplantation, which talks about whether or not some HLA alleles are actually protective. And so I think that comes up as well, but that hasn't specifically been looked at in lung transplants.
So, why, and maybe Marty knows the answer to this, has anyone tried to do a simultaneous bone marrow transplant and lung transplant at the same time? And what happens to the boss in that situation?
Yeah, it's been done. If you took a long time ago, we take vertebral bodies from donors, and you grind them up and put in the CD34 positive stem cells. There was a decreased incidence of acute rejection, but only in certain organs. So it can work with livers, which we think a lot of things work with livers. It worked reasonably well in hearts, which is not a very lymphatic organ compared to the lung. And in the lungs and the kidneys, yeah, there have been a few that have been done. There's a couple of trials in kidneys right now that have looked at full-on allogeneic bone marrow with the transplants in myeloma patients. And they've actually done fairly well with both decreased acute and chronic allograft rejection. But in lung transplants, I can only think of a handful that have been done.
Okay, last question, Brad.
What's the status of living-related lung donation versus cadaveric donation?
Oh, yes. So we don't do living-related lung donation here. Just for a little background as to what it is. Essentially, it's when a donor donates a lobe of the lung to usually a recipient that is smaller, so pediatric recipient and or small lady. Have we ever done one here? Yeah, we've never done one here at the University of Colorado. I know that they're actually much more prevalent in, say, Japan and other countries, but I have not seen them done very commonly in the United States. Usually the strategy at this time for increasing the donor pool really include use of extended donor criteria and then ex vivo perfusion to try to recondition lungs. So,
Thank you.
thanks.